بسم الله الرحمن الرحيم. نبدأ إن شاء الله. دكتور عماد تفضل.
بسم الله الرحمن الرحيم. It gives me a great pleasure to be in this educational program and to present a constellation of doctors specializing in cardiology in Egypt and the Kingdom. Yesterday, the wonderful Dr. Usama Hadrami gave us a lecture on non-Ist in a simplified and intense manner, which made us swim with our imagination and made us more understanding and the ability to deal with these cases, and about the surgical intervention and the appropriate and the correct timing for the treatment of these cases by Almighty Dr. Ashraf Fawzi. The heart is life, and through the door, وَمَنْ أَحْيَاهَا فَكَأَنَّمَا أَحْيَا النَّاسَ جَمِيعًا. We continue our successful scientific journey today with our distinguished professors. Now, we'll start with Dr. Muhammad Omar, consultant of cardiology at Al-Azhar University in Egypt and at SGH Madinah. Let us to start. تفضل دكتور عمر.
Assalamu alaikum wa rahmatullah. Welcome my colleague and my professor joining us today. And thanks for Symposium moderator for this invitation. It's a pleasure to spend such valuable time to share some ideas about our work. Today, we will talk about revascularization of acute coronary syndrome. Acute coronary syndrome is now the most famous and most killer all over the world. When we talk about revascularization, we have to know, especially coronary revascularization is typically the restoration of blood perfusion and the coronary patency to the heart muscle that suffered from ischemia. Regarding acute coronary syndrome patient will come as a new coronary artery disease or as acute worsening of stable patient with coronary artery disease. Acute coronary syndrome based on ECG and cardiac biomarker, especially high sensitivity troponin, will be categorized into three categories. The most risky one is ST elevation myocardial infarction, and this has unique ECG changes characterized by persistent ST elevation and increase in high sensitive troponin. The second one also belongs to the term of myocardial infarction, and it's named Non-Ist elevation myocardial infarction, sharing the same criteria of elevated cardiac biomarkers, but has no ST elevation. Maybe ST is depressed or transient elevation. The last one is unstable angina, which is characterized by normal cardiac enzymes, whatever ECG is normal or has STD deviation. If we talk about revascularization of ST elevation myocardial infarction, we have the old era of pharmacological perfusion, which is carried out by injection of intravenous lytic therapy, not followed by coronary angiography, either taken pre-hospital or in hospital. The most famous and most new strategy is a mechanical reperfusion, which is carried out by primary percutaneous coronary intervention in cath lab in patient not receiving fibrinolytic therapy, or the last strategy, which is a mix of both previous strategies, including patient receiving intravenous fibrinolysis, followed by transport to PCI capable center for intervention. If you are talking about the critical time of revascularization, time here play an important role in the survival and the prognosis for patients with acute coronary syndrome. The amount of muscle, cardiac muscle, that can be saved by perfusion is always related to the time flow restoration time. The short time to perfusion, the more cardiac muscle saved for this patient, and the least complication for this patient. Also, in trials, 30-day mortality, they found 51% increase in mortality if the call to balloon time or if the call to reperfusion time is prolonged more than 150 minutes. So delayed door to balloon time and the total ischemic time are linked to increased mortality. In recent analysis of trial feedback intervention time to treatment STEMI, in 2,000 people, they found that there is a strong impact of time delay on mortality, particularly when the patient has complication like cardiogenic shock or out hospital cardiac arrest. If you look at the diagram in the left side, we can easily compare the rate, the big difference in complication between the red arrow, which shows early reperfusion at 90 minutes, and the green arrow, which showed late reperfusion after 180 minutes. Also, if we look at the right panel, we can see the red curve, which resembles the most worst scenario for patient with acute coronary syndrome. Those patients has cardiogenic shock. They carry the maximum risk and the maximum rate of complication for those patients. We can easily identify the difference between early reperfusion within 1 hour, as carried out by this red arrow, and late after 100 or more than 2 hours by the green arrow. Because of this, the time for revascularization is very critical for the survival of the patient, for decreasing the mortality, for decreasing the complication along the course of the disease. If we comparing two strategies for patient with myocardial infarction, fibrinolysis versus primary PCI, there is several randomized trial demonstrated better outcome with primary PCI with stenting compared to fibrinolysis. One of this trial is the Danish trial 2. This trial categorized the patient with myocardial infarction into 3 categories. The first category on the left side, those patients receiving only lytic therapy. The second group, those underwent or undergo primary PCI with transfer. With transfer means this patient received in hospital, has no cath lab, and transferred to another center with primary PCI capable center. And the third group, primary PCI without transfer, means this patient received in large hospital with cath lab and primary capable center. The end point of this study was this myocardial infarction and stroke at 30 days. This trial is stopped early by safety and efficacy committee due to the marked decrease in morbidity and mortality for those patients carried out by primary PCI. If we see here, the red column resembles the patient receiving lytic therapy, and yellow and the blue column for those patients receiving primary PCI. There is a statistically significant decrease in mortality and morbidity for the arm of primary PCI. Even though there is also remarkable difference between patient received directly to primary PCI capable center, lower than those receiving in hospital non-capable for primary PCI. Because of this, the European Society Guidelines 2018 of revascularization strategy is recommended over fibrinolysis within the indicated time frame. As we said before, time is a muscle for revascularization. So all this benefit of primary PCI is achieved within the time window of 2 hours of transfer or 1 hour in hospital with cath lab. All this cardiogenic shock, I make one slide for this because this is the worst complication facing cardiologists in patients with acute coronary syndrome, and always the concept is different from other stable patients. Patient with cardiogenic shock, the observational data like GHOST trial or controlled shock trial suggesting benefit from early invasive strategy with BCI rather than using lytic therapy. On the other hand, they stated that fibrinolysis generally not effective for this patient. However, it may be beneficial if the BCI is not available within the time window. This is another diagram showing the critical value of the time in reperfusion to mortality and morbidity for patients with acute coronary syndrome. If we see here this curve, and we see the red arrow at the first hour of ischemic time compared to 2 hours of ischemic time compared to 3 hours of ischemic time, the worst prognosis was beyond 120 minutes or 2 hours of ischemic time. Primary BCI is now the standard or gold standard therapy for ST elevation if time to primary BCI is less than 2 hours. Again, the European Society of Cardiology guidelines stated that primary BCI strategy is recommended over fibrinolysis within the indicated time of frame as an important issue in the recommendation. Now we will compare complete versus culprit-only BCI. Here we are. Now we received the patient with acute myocardial infarction, anterior myocardial infarction. Patient either received in hospital with capable center or transferred to another center with cath lab. Patient in cath lab, logically we will find the total LED because of anterior MI, but not all patient has the same scenario. Most of cases, patient has culprit lesion, LED, and another significant lesion in right coronary and left circumflex. So what we will do in this situation? Recent meta-analysis of many trials shows that complete revascularization was associated with lower risk of mass, MI, and stroke and death. If we see here in the green circle, or we will find most of trials are suggesting or are with the concept of better outcome with complete revascularization. But most of these studies support the concept of fold revascularization, but there is gap of evidence in the proper timing of staged BCI and the tool to assess the non-culprit lesion. For example, if you, number one, you will open the culprit lesion, LED, what you will do with RCA and LCX. You will proceed to complete revascularization on the same session during primary BCI. This is one strategy. Or you will shift the patient to CCU, but you will recall the patient again during the same hospital admission to complete your revascularization. This is second strategy. Or you will discharge the patient to be completely stabilized and recall the patient again to complete revascularization. Most of the studies suggesting the complete revascularization in the same setting of primary BCI for simple and straightforward lesion in stable patient, especially if the lesion are critical or the patient has persistent ischemia after BCI. Guideline of European Society on Revascularization stated clearly that routine revascularization of non-infarct related artery lesion should be considered in patients with multivessel disease before hospital discharge. The other issue remaining is how to estimate or how to be sure or what are the standard for all cardiologists to specify significant or non-significant non-infarct lesion. Now, the recommendation to use FFR or IVUS or OCT as approved tools to assess the significance of non-culprit lesions. Cardiogenic shock, again, because it's always has different concepts. Although we said for a patient with a stable myocardial infarction that complete revascularization is beneficial and recommended, the large trial recently published culprit shock trial showing significant risk reduction in all-cause mortality with the arm of carboplatin only, and didn't recommend complete revascularization in patient with cardiogenic shock. So the difference here is the stability of the patient. We always found that hemodynamically unstable patient needs short intervention time, needs short procedure, because prolonged procedure and prolonged time will aggravate more complication and more worse prognosis for this patient. Here is the recommendation of primary of European Society Cardiology regarding this issue. They stated that in cardiogenic shock, routine revascularization of non-infarcted lesion is not recommended during primary PCI and classified as class 3 level of evidence B. This is on the other way of recommendation to stable acute myocardial infarction. Fibrinolysis, although primary PCI is the preferred regimen of STEMI, but studies noted that the mortality benefit we gain from primary PCI for acute MI is almost nullified or lost when the time delay to primary PCI was more than 2 hours. So the recommendation here, if the primary PCI is not accessible within 2 hours, it's better to start with fibrinolysis, on-site fibrinolysis, and the recommendation also, if the on-site fibrinolysis indicated, you should be given within 30 minutes, because as we said before, revascularization time is a muscle for this patient regarding prognosis and mortality benefit. In absence of contraindication, sure, for lytic therapy. So fibrinolysis message, if primary PCI can't be performed in a time fashion, the second step is to administer as soon as possible within 30 minutes, then followed by transfer to PCI capable center for routine coronary angiography in all patients within 2 to 24 hours. Surgical revascularization in STEMI. Coronary artery bypass graft here is considered a strategy of choice if there is ongoing ischemia in large area of damaged myocardium, if the PCI of infarcted related artery can't be performed, either for inaccessibility or failed mini trial to bypass this lesion. Now we will start another type of acute coronary syndrome, which is non-Ist elevation myocardial infarction, and its revascularization is a little bit challenging and different from acute MI. The first issue, what strategy will take for patient with non-Ist elevation myocardial infarction? Early invasive with coronary angiography or conservative strategy with medical treatment. Invasive strategy has become the standard of care, especially for high-risk patients, due to improved clinical outcome based on recent meta-analysis. If we show this diagram and the result of meta-analysis comparing or favoring the early invasive versus conservative strategy, we will find most of trials are favoring early invasive therapy. Regarding the time of angiography and intervention, a large meta-analysis published in 2017 showed decreased mortality and survival benefit of the early invasive strategy in high-risk group. They classify the patient with acute coronary syndrome, non-Ist elevation, myocardial infarction according to their presentation into 3 categories. For those with established diagnosis of non-Ist and hemodynamic instability or cardiogenic shock, or those with recurrent or ongoing chest pain refractory to medical treatment, or associated with life-threatening arrhythmia or cardiac arrest, or has mechanical complication or acute heart failure, acute pulmonary edema, those patients are classified as very high risk. And this group will benefit from immediate invasive coronary angiography before 2 hours. The other group, for those established diagnosis of non-Ist elevation myocardial infarction based on cardiac troponin and has dynamic Ist changes or stratified by risk score, especially GRACE score, that are recommended from last guideline, and they has high risk score, more than 140, they will benefit from early invasive strategy in the first day of presentation. The last category, which has intermediate risk, those with diabetes mellitus or mild renal impairment or congestive heart failure or LV dysfunction, or early post-infarction angina, or prior PCI or CABG, or stratified by risk scores in the gray zone, less than high and more than moderate. This group will benefit from invasive intervention in the first 3 days of presentation. Regarding the type of revascularization for patients with non-STEMI, the first one is percutaneous coronary intervention. Here, we will target the culprit vessel to be managed first. Regarding multi-vessel disease, complete revascularization of significant lesion should be attempted in multi-vessel disease as it has a better outcome, looks like stable patient with STEMI. The judgment of the lesion and its significance, they stated that FFR is feasible and reliable, safe and effective for functional assessment of lesion severity in patient with multi-vessel disease. Again, cardiogenic shock has unique recommendation, non-culprit lesion strategy in patient with non-Ist elevation myocardial infarction and the cardiogenic shock is harmful and not recommended. As we see, patient with cardiogenic shock always has unique recommendation. The second type of revascularization for patient with non-Ist elevation myocardial infarction is a coronary artery bypass graft. Optimal timing of non-emergent CABG in non-Ist acute coronary syndrome patient should be determined individually for each patient according the comorbidities and according to the size, area of ischemia and its symptoms. In patient with ongoing ischemia or hemodynamic instability with an indication for CABG, emergency surgery should be performed and not postponed as a consequence of anti-platelet treatment exposure. Even the patient on Plavix, we have to proceed with CABG to because we will shorten the time of revascularization. PCI versus CABG for patient with non-Ist elevation myocardial infarction. Unfortunately, there is no randomized comparison of PCI versus CABG in a specific setting of acute coronary syndrome stated in the guidelines. But recent data analysis from large trial, including syntax study, was including stabilized non-Ist elevation MI, showing a significant lower of complication with CABG more than PCI. So Stabilized cases should be managed as the same risk stratification of stable coronary artery disease using the available score like syntax score, which is recommended now. On the other hand, for complex cases, heart team discussion and use of syntax score are recommended to be used to judge each case individually according to the comorbidities and significance of intervention. Regarding fibrinolysis in non-ST elevation myocardial infarction, I brought this slice from the old American Heart Association guideline because nowadays no more talk about fibrinolytic therapy in non-STEMI. The American Heart Association stated that fibrinolytic agent had no significant benefit effect, also increase the risk of myocardial infarction, and such therapy is not recommended at all in patients with non-ST elevation myocardial infarction. This is the end of my slides and the time to say thank you.
Thank you, Dr. Omar, for this fruitful lecture. You brought us on the way how to manage a patient invasively and non-invasively. Thanks for this great and intellectual lecture.
Thanks, Dr. Ahmad, and thanks for our colleagues joining us.
Great thanks, Dr. Muhammad Omar, our cardiology consultant in Saudi German Hospital, Al Madinah Munawwara. And as we see together this lecture, Dr. Omar touched a very important and critical points in acute coronary syndrome, like cardiogenic shock, which is still the nightmares for the cases of acute coronary syndrome. And he touched also the intervention versus waiting for the medical treatment in non-STEMI, cabbage versus PCI, and also the fibrinolysis in non-STEMI, which is a debatable point. Still no clear evidence for that. So as we see every day and every time we have a new data about the acute coronary syndrome, we will shift our mind now to the second lecture, which is also one of the very important lectures. Dr. Tariq Zulfakkar, the professor of cardiology in Zagazig University in Egypt, and the cardiology consultant in Madinah National Hospital, Madinah Munawwara. We will enjoy with him about atrial fibrillation with acute coronary syndrome. This is one of the very critical and very important issue related to acute coronary syndrome. So we will start with Dr. Tariq Zulfakkar.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
وعليكم
دكتور.
السلام دكتور طارق.
زي الحال، اخباركم ايه؟
الحمد
انتوا
لله.
You are welcome, Dr.
عندكم
Tariq.
دلوقتي؟
The screen is clear to you, Dr. Tariq?
كلير دلوقتي.
طيب okay. I will take the second slide when you tell me. We are ready.
طب يعني انا اقول دلوقتي نيكست مثلا عشان تغير ولا اعمل ايه؟
لا next.
انا ما اقدرش اغير من عندي.
ايوه next.
طب هقول نيكست لو حبينا نغير. تمام. هنبدا دلوقتي ولا نبدا امتى؟
اتفضل دكتور طارق. The mic with you.
بسم الله الرحمن الرحيم والصلاه والسلام على سيدنا محمد وعلى خاتم الانبياء والمرسلين. We thank to the group of Saudi German Hospital who invited me to attend this lecture and symposium about acute coronary syndrome. Welcome to all the audience. We'll talk today about acute coronary syndrome and atrial fibrillation and anti-thrombotic management in atrial fibrillation patients undergoing PCI, European and American perspective. Next. We'll talk about European Society of Cardiology guidelines published in 2020. These guidelines, general guidance in it, talk about balanced risk of bleeding and ischemia, aspirin up to discharge 1 week or 1 month, depending upon this balance, dual therapy and NOAC plus clopidogrel, little data about prasugrel and ticagrelol for 6 to 12 months, depending upon this balance. Next. This is a summary of the plan. Previous one, please. Yes. The summary of the plan in atrial fibrillation patient with undergoing PCI in acute non-ischemia or acute coronary syndrome. The default management recommend triple therapy, NOAC plus the double antiplatelet, aspirin plus B2Y12 receptor inhibitor, clopidogrel, or refer to beta clopidogrel or Plavix. Double therapy and for 1 week, then double therapy until 12 months. In case of high bleeding risk, we'll use double therapy for 1 month and then 6 months, and then for complete with NOAC alone for the other 6 months. And triple therapy for 1 month in high risk for ischemic risk patients, and continue for 12 months with double therapy, NOAC, and single antiplatelet therapy. Next. The question now, all patients receive aspirin as part of their PCI procedure. More and more, the question becomes, how long should patients receive aspirin? The answer, each patient is different, and you must assess the balance of ischemia versus bleeding risk in individual patients. Next. Why they prefer to drop aspirin after PCI in these conditions? Aspirin inhibits prostaglandin synthesis, which has gastroprotective functions and therefore causes gastric erosion and bleeding. At higher doses, by inhibiting prostaglandin, which is a vasodilator, leads to prolonged use of aspirin may promote vasoconstriction. Aspirin is a weak antiplatelet compared to other antiplatelets. Low-dose aspirin was better than high-dose aspirin when combined with ticagrelol in plateau study. Higher rates of bleeding and in the current study also was shown with the use of higher dose of aspirin. A WOST trial-like strategy, dropping aspirin altogether was superior to triple therapy. Next. These are the general recommendations regarding atrial fibrillation and concomitant anti-platelet therapy. General recommendation. In atrial fibrillation patient eligible for NOAC, it is recommended to use a NOAC in preference to vitamin K antagonist or in combination with antiplatelet therapy. Class 1A recommendation. Next. Second recommendation here, in patient with high bleeding risk, has bled 3 or more, rivaroxaban 15 milligram OD should be considered in preference to rivaroxaban 20 milligrams. Then we use 15 milligram only once still for the duration of concomitant single or double antiplatelet therapy to mitigate bleeding risk. In patient with high bleeding risk also has bled more than 3, this class 2A level B. In patients with at high bleeding risk, which has bled 3 or more, dabigatran also 110 milligram BID should be considered in preference to dabigatran 150 milligram BID for the duration of concomitant single or double antiplatelet to mitigate bleeding risk also. This is also class 2A level of evidence B. Other recommendation in atrial fibrillation patients with an indication for vitamin K antagonist combination with antiplatelet therapy, the vitamin K antagonist dosing should be carefully regulated to target INR from 2 to 2.5 with treatment to target ratio more than 70%. يعني should be to lower level 2 to 2.5. Next. These are the thrombotic risk of the patient. Number 1, diabetes mellitus requiring therapy, prior acute coronary syndrome or recurrent myocardial infarction, multivessel coronary artery disease, concomitant peripheral artery disease, premature or accelerated coronary artery disease, chronic kidney disease with GFR more than 60 milliliter, less than 60 milliliter per minute. Here are clinical presentation of acute coronary syndrome in the acute stage, multivessel stenting, complex revascularization with bifurcation of two stents, prior stent thrombosis on antiplatelet therapy, and procedural factors. Here, these factors prolong the use of antiplatelet therapy. Next. These are the bleeding risks: hypertension, abnormal renal or liver function, stroke or intracranial hemorrhage history, bleeding history or diathesis, labile INR with the use of vitamin K antagonist, elderly patients above 65 years, drugs, oral anticoagulant, antiplatelets or non-steroidal antiplatelets. Those factors reduce the use of antiplatelet therapy if has bled more than 3 or 8. Next. Acute coronary syndrome with atrial fibrillation and concomitant antiplatelet recommendations. In atrial fibrillation patient with acute coronary syndrome undergoing an uncomplicated PCI, early cessation less than 1 week of aspirin and continuation of dual therapy with an oral anticoagulant and B2Y12 inhibitor, preferable to be clopidogrel, for up to 12 months is recommended if the risk of stent thrombosis is low or if concerns about the bleeding risk prevail over concern about risk of stent thrombosis, irrespective of the type of stent. Plus 1B. And if there is atrial fibrillation, we use always stop aspirin after 1 week and continue single antiplatelet therapy with oral anticoagulant for 12 months. Next. Triple therapy with aspirin and clopidogrel and oral anticoagulant for longer than a week after acute coronary syndrome should be considered when risk of stent thrombosis overweighs the bleeding risk, with the total duration equal to or less than 1 month, decided according to the assessment of risk factors in the treatment of this patient. Next. Here, the plan in atrial fibrillation with acute coronary syndrome, the same as we told before, oral anticoagulant will continue from the PCI until 12 months. In addition to ticagrelol or clopidogrel preferred with the oral anticoagulant, also up to 12 months. And if there is bleeding risk, enough to be only 6 months. Aspirin will continue for only 1 week and can be extended in case only in cases of increased thrombosis risk and high thrombosis risk. Next. Here, percutaneous coronary intervention, atrial fibrillation with concomitant antiplatelet therapy also. Next. After uncomplicated PCI, early cessation of aspirin within 1 week and continuation of dual therapy with oral anticoagulant up to 6 months, and the clopidogrel is recommended if the risk of stent thrombosis is low. And in case of risk of thrombosis is low, we can enough to be 6 months, not 12 months. And if there is a respect about bleeding risk, prevail over concern about risk of stenosis thrombosis, irrespective of the type of stent used. And if the bleeding is more, we can use only for 6 months after elective BCI. Elective BCI, not acute coronary syndrome. Next. Triple therapy with aspirin, clopidogrel, and oral anticoagulant for longer than a week should be considered when risk of stent thrombosis outweighs the bleeding risk, with the total duration less than 1 month or 1 month, decided also according to the risk of the patient and the bleeding. Next. This is the plan. Oral anticoagulant for 12 months can be with clopidogrel, single antiplatelet for 6 months in case of high bleeding risk. If low bleeding risk, we can continue for 12 months also. Aspirin, same, can be extended to 1 month in high risk thrombosis as a triple therapy. Next. Bleeding reduction strategies to reduce bleeding associated with BCI. Usually we use radial artery access, BBIs in patients taking double antiplatelet who are at increased risk of bleeding, e.g. elderly, dyspepsia, gastroesophageal reflux disease, Helicobacter pylori infection, chronic alcohol abuse. Non-administration of unfractionated heparin in patients with vitamin K with INR more than 2.5. Pre-treatment with aspirin only. Add clopidogrel in B2Y12 inhibitor when coronary anatomy is known or if there is STEMI. GB2B3A inhibitor only if bailout or procedural complication. Shorter duration of combined antithrombotic therapy. Next. These are the Europe versus North American or American school, American College of Cardiology. Before, in 2020, the American College of Cardiology, in stable patients, they preferred only to do dual antiplatelet, dual antiplatelet only with aspirin for only 1 week in 8 cases, in acute coronary syndrome and in stable condition. While in 2020, European Society guidelines recommends aspirin up to 1 month in cases of high risk of thrombosis. This recommendation of American College of North American consensus updates in 2021, they updated that they can use triple therapy for 1 month in acute high risk acute coronary syndrome patients, like, and become similar to Europe recommendation. Next. These are the recommendation of North American perspectives. Next. In 2021 updates. Here, next. Pre-procedural consideration before defines the appropriateness of BCI procedure should be according to the guidelines. Ischemic thrombotic and bleeding risk estimation, this number 1. 2, procedural consideration will use vascular access to the radius, and stent selection will be new generation drug-eluted stents. And post-procedure consideration should be close monitoring with reassessment of risk profile and recommend of use of BBIs and avoid non-steroidal. Next. Here, the pre-procedure defined appropriateness of BCI procedure should be highly indicated. Ischemic thrombotic bleeding risk should be stratified. Next. These are the risk stratification and how to determine the risk of according to the bleeding risk academic research consortium, high bleeding risk patients. And here, these are the factors which may favor bleeding risk, including chronic kidney disease, GFR less than 30, this one, and hemoglobin less than 11, and spontaneous bleeding within the last 6 months, moderate to severe baseline, also liver disease, chronic kidney disease, bleeding dialysis, and recent intracerebral hemorrhage. All these are risks which increase the bleeding risk to determine high-risk patients who can only take doubles or triple, only double or single antiplatelet beside oral anticoagulant for only 6 months. Next. Here are definitions of high thrombotic and ischemic risk. High thrombotic risk in early events include acute coronary syndrome, prior stent thrombosis, BCI complexity, 3 vessel disease, more than 3 stents implanted, 3 lesion treated, bifurcation with 2 stents implanted, total stent length more than 60 millimeter, surgical bypass graft BCI, chronic total occlusion BCI, atherectomy device use, a left main BCI. All these recommend that prolonged triple therapy use for 1 month. Also, the high risk ischemic risk include prior myocardial infarction, multi-vessel coronary artery disease, polyvascular disease, diabetes mellitus, chronic kidney disease, and heart failure. Next. According to procedure consideration, we should use vascular access, the radial access, and stent selection, new generation drug-eluting stent. Next. These are the pre-procedure management of oral anticoagulant therapy in patients on chronic treatment undergoing a non-emergent BCI, interrupted versus uninterrupted approach. According to the European side, elective BCI should be, in cases of a vitamin K antagonist, uninterrupted therapy should be performed, and add parenteral anticoagulant in cases of INR less than 2.5. In case of use of NOAC, elective BCI will interrupt strategy preferred 12 to 48 hours according to the use. In non-STEMI acute coronary syndrome, uninterrupted strategy preferred, and add parenteral anticoagulation besides the NOAC. In European side guidelines, the same uninterrupted strategy with vitamin K antagonist, and use anticoagulant with INR less than 2.5. In NOAC, uninterrupted strategy preferred, and add parenteral anticoagulant with them. On the other hand, American College of Cardiology consensus and North American perspectives, they interrupt the therapy is preferred with vitamin K, defer the procedure until the INR less than 2, and interrupt the strategy preferred also in case of the procedure is at least 24 hours or up to 120 hours based on the agent and the renal function in case of and radial or femoral process. In vitamin K interruption, it should be interrupted on the INR less than 2 in the radial axis and 1.5 in the femoral axis. In NOAC, interrupted also strategy should be done for 24 hours to 48 hours, even in acute coronary syndrome. This in case of 24 hours, in case of dabigatran or impaired renal function. Next. These are the North American perspective. It is now considered in default strategy. We use aspirin only for triple therapy, oral anticoagulant with that for only 1 week, and double therapy for 12 months, oral anticoagulant and the B2Y2 inhibitor, clopidogrel. After 1 year, it will be oral anticoagulant alone. In the patients with high risk of ischemic thrombotic risk, we use triple therapy for 1 month and double therapy for 12 months, and then oral anticoagulant alone after 1 year. In patients with low ischemic and high bleeding risk, triple therapy for 1 week only, and double therapy for 6 months, and oral anticoagulant alone after 6 months. Next. Then, according to this, NOAC should be the oral anticoagulant of choice and used at stroke prevention doses. Alternative doses can be considered if specifically tested. And single antiplatelet should be started as soon as possible, preferring B2Y12 inhibitor over aspirin. Drop aspirin in this situation. Next. Next. The same as we tested. What then? This algorithm choice of oral anticoagulant. In the absence of contraindication and NOAC used at stroke prevention doses, alternative doses can be considered if especially treated. Should be preferred over vitamin K antagonists in AF patients undergoing PCI. Lack of head-to-head comparison do not allow to recommend one NOAC over another. The selection of a specific agent should take into consideration the trial design which is given NOAC we tested. Patient access to individual NOAC based on availability and cost may be also a driving factor as implication of the process. May also prefer one NOACs administered once daily, like Revascularization and Edoxaban, versus twice daily Dabigatran and Apixaban. Avoid switching between NOAC in the patients who have already been adherent without complication on a specific agent. In the absence of contraindication, and if the drug access is not a limiting factor, patients on vitamin K antagonist prior to ACI should be considered switching to NOAC. Vitamin K remains the only indicated oral anticoagulant for patients with moderate to severe mitral stenosis with mechanical prosthetic heart valve and left ventricular thrombus or other hematologic reasons, e.g. Antiphospholipid syndrome. Next. Single antiplatelet should be started as soon as possible. And preferring B2Y2, preferring clopidogrel is the preferred one. Next. We should always weigh between bleeding complications and thrombotic complications. Next. Post-procedure, we should make close monitoring with reassessment of risk profile and recommend use of BBIs to avoid non-steroidal antibiotics. More frequent follow-up visits should be done. Don't leave in the exclusive care of for primary care physician. Choice and duration of anti-thrombotic therapy may change over time depending on clinical evaluation. At 1 year post-PCI, need to continue with any antiplatelet agent based on bleeding and thrombotic risk. Next. More recent data brings synchrony to atrial fibrillation and plus PCI guidelines and recommendation between the American and Europe. Now they are the same. Next. These are the guidelines in European guidelines on the right side and North American guidelines consensus, the same. 1 week for triple therapy for all patients, extended in high thrombotic patients for 1 month, and single antiplatelet can be oral anticoagulant for 1 year, and except 6 months only in case of high bleeding risk. Next. The problem, you cannot simultaneously prevent all three: stent, thrombosis, myocardial infarction, and stroke, and major bleeding with the use of oral anticoagulant and double antiplatelet. Next. These are the guidelines as we told before. Next. And these are the anti-urgent the guidelines as we discussed before. Next. These are the American, North American clear as we discussed before. Next. Here, in conclusion, in patients with atrial fibrillation and recent acute coronary syndrome or PCI, the use of NOAC plus B2Y12 without aspirin should be regimes that include vitamin K antagonist plus B2Y12 inhibitor plus aspirin. Traditional triple therapy should generally be avoided. Revascularization 15 milligram OD or dabigatran 150 BID or 110 BID, high risk for bleeding. Apixaban 5 milligram BID, edoxaban 60 milligram OD. Apixaban 5 milligram BID for acute coronary syndrome medically management. Next. These are no interruption of vitamin K antagonist, vitamin K or non-vitamin K oral anticoagulant, NOAC, is needed if a radial approach is chosen among patients undergoing invasive management on chronic systemic anticoagulation. For most patients who undergo PCI, NOAC is preferred over vitamin K for stroke prevention related to atrial fibrillation and elevated thromboembolic risk. Triple antithrombotic therapy with aspirin, B2 inhibitor, and NOAC for 1 week, followed by NOAC, and the single antiplatelet therapy, preferably corticosteroid, is recommended for 12 months. For patients who are at high ischemic thrombotic risk, triple anticoagulant antithrombotic therapy can be continued for up to 1 month. Use of Hasbled and ARC-HPR are useful to assess bleeding risk in individual patients to facilitate informed decision making. Next. These are the trials because some questions not yet will be established. This Optima 3 trial in atrial fibrillation, acute coronary syndrome, and PCI in China. This one will compare vitamin K antagonist with double antiplatelet for 6 months compared to vitamin K antagonist with double antiplatelet for 1 month. Then followed by vitamin K with clopidogrel for 11 months. The other arm will only 6 months and 6 months. The results not yet come. Optima 4 also, atrial fibrillation, acute coronary syndrome, PCI also, used dabigatran beside double antiplatelet for 1 month compared to 6 months. And if there is bleeding risk or ischemic risk with you. Yani one trial Optima 3 with vitamin K antagonist to compare 1 month compared to 6 months triple therapy, and the other months Optima 4 to compare dabigatran for 1 month compared to 6 months triple therapy and check the bleeding risk in those patients. Next. Untitled 3 trial, atrial fibrillation also in Netherlands and Belgium. They compared DWAC plus double antiplatelet for 1 month and DAPT alone. If we use a double antiplatelet alone without oral anticoagulant for 1 month, is there a difference? Or we should combine with double antiplatelet for months, and the rest of the months will be oral anticoagulant with clopidogrel alone. This is to check if we omit the oral anticoagulant for 1 month, is there, and use double antiplatelet will be better or not. Next. In this ongoing studies to check duration of triple therapy or the oral anticoagulant plus double antiplatelet after PCI in atrial fibrillation is still not fully clear, 1 month or 6 months. This is Optima 3. Does this apply to both vitamin K and DWAC, Optima 3 and 4? Can we reduce safely early bleeding with double antiplatelet only without oral anticoagulant during the first months after PCI? This is the worst 3. Next. Thank you for attention. And I hope everyone has a question. I'm ready to answer any question of the audience. Thank you.
Great, thanks, Dr. Tariq, for this nice presentation. Really, we had been enjoyed for these data about atrial fibrillation with acute coronary syndrome. We will open the discussion for the 2 lectures. And Dr. Ahmed, if he had any question collected, he can start.
Thank you, Dr. Tariq, for this intellectual lecture. You brought us in the way how to manage patients with high thrombotic risk or bleeding risk as regards to antiplatelet and anticoagulation. I have a question. If there is patient to come to us with GIT bleeding or intracranial hemorrhage and acute coronary syndrome, what should I do, Dr. Tariq?
There is acute. There will be acute. This patient will be managed medically and cannot interfere with this patient by any means. If he has already hemorrhage, intracranial hemorrhage, it's contraindication, absolute contraindication to use anticoagulant. What can you do? You will kill the patient if you use any anticoagulant. You will increase the hemorrhage risk. You are trying to save the patient by any means. You weigh the benefit against the cost.
Even if he come to us with a STEMI?
You cannot manage now. How can you add anticoagulant in a patient with intracranial hemorrhage? Is there any recommendation from the neurologist to use any anticoagulant while there is intracerebral hemorrhage? You should control first the hemorrhage, then intervene with the patient if you want.
Okay, thank you, Dr.
Otherwise, you'll kill the patient by any means. What is the benefit of BCI at that time?
Okay.
And should take care about the bleeding first. Stop the bleeding, then start your management.
Okay.
Even according to the guidelines, American guidelines, if the patient is oral anticoagulant, and according to them, you do not intervene, you should interrupt the anticoagulant therapy before the intervention. This is the school of American school. Then you can defer the intervention until control of the situation. If you have excessive anticoagulation, or if you have bleeding, active bleeding, then you can defer the intervention until you control the problem.
Okay. Thank you, Dr. Tariq, for this fruitful answers.
Thank you.
Dr. Omar, as regards Dr. Omar, I need to ask a question about if we are in cath lab and we cannot detect the culprit lesion, what we should do?
Hello, Dr. Ahmad, you hear me?
Yes, Dr. Omar.
Again, your question.
If I have patient in cath lab, bring to us with non-STEMI and we cannot detect the culprit lesion, what should we do?
Yes, this is a good question, and this is the area I stressed on this, using the available tools or to judge the specific stenotic or severity of the lesion. Number one, FFR أو IFR or ACT or IVUS. These tools now are widely used to assess the most significant lesion. You with me?
Yes, Dr. Omar, we are with you.
Yeah.
Thank you, Dr. Omar, for this answers. Dr. Tariq, there is a question.
Yes.
If I have patient come to us with acute coronary syndrome and the AF and has already aspirin sensitivity, hypersensitivity, what we can do?
Now aspirin is deferred. Now it is not recommended for all patients because, as we told you in this lecture, that there is drawbacks for aspirin because increase gastric irritation. It is weak anti-platelet. That depend mainly on clopidogrel or ticagrelor, or and the addition of aspirin is if there is any contraindication for aspirin as regard to hypersensitivity, it cannot be used by any means. But you cannot use other except only one anti-platelet, clopidogrel or ticagrelor. Prasugrel is not recommended at all in combination with oral anticoagulant. And there is another study that showed that even double single antiplatelet beside oral anticoagulant is not too much enough, more than even triple sum.
Okay, Dr. Sar, thank you. Thank you. Dr. Omar, if we have in case lab, what you prefer anticoagulation, enoxaparin or heparin? Hello? Dr. Omar?
Okay, till Dr. Omar open his mic, there is a question came for Dr. Tariq. If the patient, Dr. Tariq, is preferred for
yes.
If one patient will blend for any intervention by surgery for any reason, it is not an emergency but elective, and he is in atrial fibrillation. Is it preferable to use bare metal stent in those patients? He developed
acute. It is the recommendation according to all guidelines, European, and to use drug-eluting stent. Don't use bare metal.
Yeah.
All the guidelines, American and European.
Okay. There is another question, Dr. Tariq.
Yes.
What if the patient with atrial fibrillation and post-PCI within less than 1 month, and he is for elective surgery? It is better to postpone the surgery, or there is another solution?
Only you can do the surgery if it is life-saving surgery. During this period, at least 6 months should be any elective surgery should be deferred at least for 6 months.
Yes. Thank you, Dr. Tariq.
Dr. Omar, a case of STEMI in ER, so he apologized about completing the lecture and the discussion. Dr. Tariq, if primary BCI failed, what we can do?
Primary BCI what? Sorry, what's the question? Failed?
If I fail to open the culprit arteries in patient with STEMI, what we can do?
And you'll manage the patient medically. You'll continue on an oral anticoagulant and single antiplatelet for 1 year.
Okay.
You cannot use thrombolytic therapy with oral anticoagulant.
Okay.
دكتور عماد.
السلام عليكم دكتور ابراهيم.
الله وبركاته. انا دكتور ابراهيم.
ازيك يا دكتور ابراهيم، اخبارك ايه؟
الله يخليك. استاذنكم ممكن بس اقول كومنت؟
اتفضل.
بالنسبه للسؤال اللي سالته دكتور عمر، اعتقد دكتور عمر عنده مشكله في المايك. انت كان سؤالك ايه بالنسبه
لدكتور عمر؟ هو دلوقتي راح عنده حاله في الطوارئ بس استيمي اعتذر واضطر يمشي.
ده كان في سؤال قبل السؤال ده، انا سالت سؤال اللي قبل كده هو ما
as regard the anticoagulation in case lab.
طبعا.
prefer special
unfractionated or enoxaparin.
بص يا دكتور عماد، هو في 2016 في الجايد لاينز نون استيمي كانوا قالوا انه دونت كروس اوفر، يعني العيان اللي ماشي على انوكسيبارين في السي سي يو ادي انوكسيبارين في الكاس لاب. لكن الحقيقه احنا اكشوالي بنعمل كروس اوفر وبندي هيبرين. ان ماي اوبينيون الهيبرين ليه ميني ادفانتج. اول ادفانتج انت عندك بتقدر تمونيتور بالاي سي تي ماشيين عندنا في الكاس لاب، البريدكتابل اكشن، كمان الانتيدوت بروتامين سلفيت موجود معاك، ستيل وايدلي يوزد الهيبرين ذان لو مولكيولر هيبرين ان كاس لاب.
And short acting.
Yes. All this advantage make heparin still superior despite non-STEMI latest guidelines. I think 2016 they mentioned don't cross over. The patient was in enoxaparin in CCU. In cath lab you give enoxaparin IV. Maybe the practice of enoxaparin IV not popular for most of us. We prefer heparin still all of us in cath lab use heparin.
Yes, yes. Thank you, Dr. Ibrahim. Dr. Tariq, what is your opinion about thrombolytic before hospital admission?
Thrombolytic before hospital admission?
During
if you have
MS.
If you have no way, you don't have intervention, you cannot reach an intervention, it is preferred to give thrombolytic as possible as you can.
I think Dr. Ahmad is...
Yes.
Dr. Ahmad speak about trained ambulance and diagnosis in ambulance. You mean this, yani, or in ER?
But here in our situation, the patient was on atrial fibrillation and already on oral anticoagulant. You cannot give thrombolytic.
Yes, yes.
You cannot give thrombolytic. The only way is to do intervention if it's possible.
Mm-hmm.
Yes. If it is diagnosed as acute STEMI in the ambulance and you have no way, you will not reach for intervention within 2 hours as you can, and do the intervention electively within 24 hours as possible, as soon as possible also. Hello?
And I have to also comment here, our ambulance system is still not developed. We don't have equipped ambulance with trained paramedics to do ECG in ambulance and diagnose and start thrombolytic in ambulance. It has many hazards. You need trained personnel, trained doctors.
We are talking about the possible guidelines if it is possible, applicable. Until now, we don't have somebody who can diagnose MI at home. We don't have somebody doing machine ECG, 12 lead ECG at home or in the ambulance, not available until now.
Yes, agree.
Thank you, Dr. Tariq, and thank you, Dr. Ibrahim. Dr. Tariq, from your experience, which antiplatelet you prefer as regard the patient presented with arrest, cardiac arrest?
Cardiac arrest, resuscitated risk?
Yes, due to STEMI.
According to my situation here in my hospital, I don't have intervention. Understand me? I don't have intervention in my hospital. That's why I use clopidogrel by any means, so that I can, if I need to give thrombolytic therapy to the patient, I can use. But if I have intervention in my hospital, I can use if the patient not in atrial fibrillation but risk after acute coronary syndrome or STEMI, and I'll do intervention with him, I can use ticagrelor, no problem. No contraindication to use ticagrelor in this situation. It will be better.
Okay, thank you, Dr.
If you do intervention, or plan to do like this. But usually, in post-myocardial arrest, the patient is unstable, and better to give him thrombolytic until you prepare him to elective intervention within 24 hours. If the patient already resuscitated and he can come back to his life, then the preferred will be in this situation to give clopidogrel, not to give ticagrelor.
Okay. Dr. Tariq, type of drug-eluting stent can affect the timing of antiplatelet?
If what? Sorry, the question?
Type of drug-eluting stent can affect the timing of antiplatelet, and for how much we use antiplatelet for 1 month, 2 months, 3 months?
The type of all the guidelines I discussed, all the same, but all for drug-eluting stent. All recommended for patients with atrial fibrillation and high-risk patient, drug-eluting stent. Don't use bare metal stent. And all them the same, no difference between. But if you are using the most recent, better, so that thrombosis will less.
last question with me, Dr. Tariq. What meaning of complex procedure?
Complex procedure, as I told in one slide, indicating that patient with more than 3 stents, bifurcation lesion with 2 stents with keloid technique. The other one is stent to left main, and stenting in total occlusion.
Okay, thank you.
Yes.
Thank you. Thank you.
Welcome.
Dr. Zenon, if there is any question?
Thank you, Dr. Ahmed. There is one question came, Dr. Tariq. If the patient with prosthetic valve and he is on warfarin on target level, INR, and developed STEMI, is there any preferred thrombolytic therapy I can give to him? If there is no
the only way to do intervention.
If there is no primary PCI access.
You cannot give him thrombolytic. It should be managed medically until you can do electively PCI for him. Hello?
Yes, with you, Dr. Tariq.
Yes, and this patient on oral anticoagulant, fully anticoagulated. It is very dangerous for him to use thrombolytic therapy with anticoagulation. It is not recommended to give, if you give vitamin K to obsolete, that already he is already anticoagulated. You will stop anticoagulation. How come? It will be more dangerous even for the STEMI.
Yeah.
Then the best procedure to do for him that you stabilize the patient until the INR less than 2.5 and make intervention electively in any other place. But you can start anti-platelet therapy beside vitamin K antagonist until you do this procedure within 1 week.
I agree.
Yes.
Thank you, Dr. Tariq.
Welcome.
We had finished our question came from our respected audience, and I will let Dr. Ahmed to close our discussion today. Thank you for all.
Thank you for all, and thank you for invitation, and thank you for all the audience, and to share our knowledge and share our experience with each other. And I hope to meet in another meeting and another symposium to discuss different items and different categories in cardiology. Thank you very much.
Thank you, Dr. Tariq. Thank you, Dr. Omar, for this great and very fruitful intellectual lectures. Thanks for our audience. And inshallah, tomorrow there is a good lecture with Dr. Ibrahim and Dr. Zem. Keep in touch. Assalamu alaikum.
Assalamu alaikum.
وعليكم السلام ورحمة الله وبركاته. شرفنا بحضرتك يا دكتور طارق.
شكرا جزيلا. السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.